which is here with us to provide a safe place that offers acute crisis intervention for children aged 6 to 12.0, okay, not 12.3, with most severe and complicated psychiatric disorders who are unable to receive any treatment not in a closed inpatient ward. Our ward, we have 12 beds, and the treatment duration varies between 2 months and 4 months. In terms of the US, it's mega, ultra long hospitalization period. They're hospitalized for 3 to 7 days. So let's go on in the tour. We are very proud on how does it look. But before I will tell you, we have 4 unique things in our department. היה לנו בעיה עם הוידאו ועם הסאונד של הוידאו, אבל נקרוא לו? בוא. הנה, זה הסרטון. כן.
תציגי את הסרטון.
אני מראה לך, תודה שבאת. זה הסרטון.
זה מיותר. רגע, לא, זה אוקיי, בסדר.
את זה אנחנו רוצים...
תציגי.
So we have 4 unique things in the department. The first thing, and we will see, it's our location. We are placed in the 3rd floor of the pediatric hospital next to the management. And I think it's a statement that mental health is a general part of all child health, not only mental health. And the psychiatry is not the backyard of medicine, but it's a central part. Also, this location, you can see here this corridor, it's the corridor to the management. So it's also a statement that we are not the backyard, we are a general part of all the physical and mental health of the children. And it also helps to reduce stigma. It's the only department which is placed in a pediatric general hospital, the only closed child psychiatric for inpatient unit for children aged 6 to 12. So one is the location. The second thing is the structure. You can see here we believe in transparency and partnership. The nurse station, as you can see here in this picture, is open, and it's not closed as in a glass aquarium, as you can see in many psychiatric wards. It provides accessibility of the staff to patients and their families. And interestingly, the child are not crossing those lines. You can see it's only lines, everything is open, and the children are not crossing these lines. Third thing is transparency. As I mentioned before, our ward is under closed video surveillance. We have more than 33 cameras in all areas of the department, including children's rooms, corridors. We don't have cameras in the bathrooms and in the staff dining room, so they won't see what we're eating. The videos are mainly for us, for learning and debriefing, but also for safety and transparency. And the fourth thing is shared hospitalization with parents during the first week. It's one of the things that we are very proud of. Hospitalization of children in psychiatric wards is stressful for children and their parents. And we conducted a qualitative study with interviewing the parents, focusing on the first week and their experience of the shared stay during the first week. And the main themes that parents reported that the first week, the parents are hospitalized with the child in the department, which is something quite unique, okay? Most of the the department, the parent goes by and then he doesn't know what's going on inside. So it enables a gradual process of separation from the child, and also a feeling of confidence and trust towards the staff. The parents see how we work, what we do, and it really helps them to trust us, and also it helps for the treatment. So the indication for hospitalization, more than 2/3 of children are hospitalized due to extreme irritability and aggressive behavior and severe impairment of functioning, as you can see here, okay? Also, we have suicidal thoughts, 4 children with psychotic episode. One of them was diagnosed with with childhood onset schizophrenia, school refusal. The psychiatric diagnoses of the children, the three leading are ADHD and learning disabilities. ODD, as I mentioned, most of the children are hospitalized due to aggression and outbursts, and autism in a variety of functioning levels, okay, and support needed. The average number of diagnoses in the Department of Children are 3, okay? They have more than 3, even 6, 7 diagnoses. We have the commando unit, which is children with ASD, with or without intellectual disability. We call them the commando. It's children that need much more support. They need they are non-verbal. Most of them are still not toilet trained, and they need really high level of support, and they require one-on-one, even one-on-2 staff. One child with 2. Now we have a child which is with a genetic disorder, which requires 1-on-2, 2 staff members for one child, 24/7. And we can accommodate only 2 such children at each time because it requires much staff. So let's take a tour, okay? You can see it's bright new and very, very beautiful. And we have the area of the children, and this is a child's room. We have rooms for the shared stay, so it's a room with a single bed and one bed for the parents. We have rooms for 2, and this is a room for 3 children. This is the nurse station, as I showed before. And this is okay. We work in a multidisciplinary team. We have more than 10 disciplines. We have a school inside the department. We have child psychiatrists, nurses, school teachers and staff, social workers, psychologists, occupational therapists, speech therapists, dietitian, behavior analysis, which we will talk about later, personal family escort, which is a unique person that also gives she's in touch with the parents, and we have students. And now Eitan will represent the
Hi. You see that we team teach.
Team teach.
I guess it's probably the only place in the globe where we have analysis and psychiatry joined together. And if you want to blame somebody, he's sitting right there. It's Professor Gothelf. This was his dream. So thank you, Professor Gothelf. We host at Sheba, we host a training certification program for behavior analysts. You can see the list of courses here. I will not go through. The most important thing is what you see down there. It's the practicum, because it's unique in a way that our students study a series of courses. You see on the right-hand side, it's the psychiatry courses, and on the left-hand side, you see the applied behavior certification courses. But the practicum is being advised by both leading psychiatrists and leading behavior analysts, and most of it is done in the department and in other sections of the psychiatry unit at Sheba and other places. So this is unique in a way. And this is the basic paradigms of behavior analysis. I guess most of you are familiar with. We analyze the discriminative stimulus, the antecedents for behavior, then the behavior, then the consequences. And you can see some examples of children that we are working with. And then we analyze it in a way that okay, I don't know why it doesn't move. That if we see that an inappropriate behavior increases, this means that something in our relationships with the kid is contributed to it. And what you see up there, MO with the medication, we call it motivational operations. This is the emotional mood of the child. And the medication has a strong effect over it, but also the behavioral treatment has an effect, and this is where we join together, and I will talk about it later. Then in our program, we have defined very clearly what we call yellow lines. And if you ask me, I think it's the most important ingredient of a program. Why? These are the precursors. If we identify those precursors that follow that, starts the escalation, and we act in this stage, then we prevent a lot of what comes next, and these are the red line behavior that forces us to move the child to a room that protects the child. It's not a timeout room. It's not a punishment room. It's a soft room that enables the child to relax and not harm him or herself and others and staff or equipment. And this is the only situation where this child is taken there. We don't provide any discussions with the child inside there. We just let the child relax, and then we continue with a sequence of steps until the child returns to typical functioning. The principles that lie within the behavioral program of the department are, first of all, and most importantly, and it's not easy when you train staff, we don't punish in any way. Sometimes, it comes naturally when we feel that we are helpless, and then we are trying to apply aversives over a child, and we are trying to eliminate it as much as possible. And then, of course, we have procedures that are designed to eliminate becoming red line, what we call red line. And I referred to it when I was talking about the yellow line behaviors that we have learned how to identify them, and the staff know exactly what should be done in order to prevent escalation. And then the functional assessment is the assessment, the behavioral assessment in which we gather data, we collect data over the children functioning in the department. And I will give some example later. So here is the general model of the department. It's small, but I will enlarge it soon. First, we have the intake that is based on functional analysis. Then our behavioral staff with the clinical managers, we define the goals for treatment. Then we define specific objectives for each child. Those objectives are tailored for each child, and they are designed in a shaping way that the child can progress from easy to more difficult. And then when the child is up there, ready to function, we start working with some of the children at home, getting them ready to transfer home and to the community. So this is the first stage when we conduct the intake based on the functional analysis. We collect general data. This is the advantage of having students practice within a department. So first of all, we'll look at the whole picture. You see on the red, it's the challenging behavior, and on the green, these are behavior that we are about to support later on and to increase them. And then on the left side, you see the context of where those behaviors occur. And on the right-hand side, you see the consequences, what we do as staff or other children are doing. And then we dig into specifically to a certain behavior that we assume is crucial. Here, for example, it's refusal. And we have a very clear picture of where refusal occurs and how do the staff react to that. So we define the behavioral objectives, and we climb step by step. All the kids, if you come to the department now and you ask a child, what is your objective? He will say it out loud, even in the middle of the night. Not only they can say it, most of them, or maybe all of them, can explain what they are expected of. And to follow this, we have a motivational program that is based on token economy. A few times a day, there is a gathering of all children, and children receive feedback from the instructors. In many cases, children themselves say what they have done right and what they have done wrong. And there are certain areas of tokens, basic tokens, tokens that are specific to the child's growth, ADL tokens that are related to the everyday activity, and a bonus token when a child is acting in an extraordinary way. They get it in front of all the others, they get explanation, and it repeats itself a few times a day, and it relates to the previous interval of time before it. And here's the challenging video. Let's see if it can work.
והסימון הראשון שלנו, סימון ערכי המחלקה. ואני רוצה לשאול אותך אם היום עמדת בערכי המחלקה, בעיניך.
כן.
כן? תן לי דוגמה.
לא הרבצתי.
לא הרבצת, זה ממש נכון, זה אחד מהערכים שלנו. אז מגיע לך סימון?
כן.
מגיע לך סימון, כל הכבוד. ועכשיו אנחנו עוברים לסימון ירוק, סימון צמיחה, כי זה אחרי זה הסימון. אתה זוכר את היעד שלך, את היעד הצמיחה שלך? מה המטרה?
שאין מה לעשות, אני מחפש משהו לעשות.
מושלם, קודם כל אני רוצה שאתה זוכר את זה, זה דבר ראשון. והדבר השני, היום היה לך מצב כזה שהיה לך משעמם ולקחת ספר נגיד וקראת?
כן.
תותח, מגיע לך?
כן.
מחיאות כפיים. מגיע לך.
So they all are familiar with the objectives of all the other kids, and they can relate to it. So just briefly, two procedures that we employ. Recreating the scene, it's very important. A day after an incident, we repeat with the child the incidents of the previous incident, and we act as if it's happening now, and we provide some explanation of why did I do it and what should I do next. And this one is recently, I'll just mention it briefly. It's a child that didn't visit his own home for almost a year, and we have provided a procedure of desensitization in which the behavior analyst sat with him in the balcony, and his parents sat in the department, and gradually, as can you see in these steps, she got closer and closer and closer and closer, and here she brought pictures of parents and the dog from home, and etc. And last week, the child returned home and stayed with his family for the whole weekend, and this was a big, big celebration.
This is how our tables look like, and I just wanted to tell you about our preliminary results about that we measured the effectiveness of our ABA model, as Eitan described. We didn't mention, but I think it's obvious that all children receive pharmacotherapy, psychological therapy, parents receive personalized and group parental training. We have social workers that support the family. The daily routines themselves are also reduce anxiety and also help the child. But we wanted to assess this treatment protocol. We have 10 children in these preliminary results. Most of them are hospitalized due to aggressive behaviors. The primary outcome, I will go through them. One is the MOAS. MOAS is Modified Overt Aggression Scale. It's a scale that rates the patient aggressive behavior in 4 categories. Here it's not verbal aggression, it's physical aggression, okay? Physical aggression, autoaggression, aggression towards themselves, against property, and verbal aggression. It was developed in a closed psychiatric ward to track aggression and aggressive acts over time. It measures the frequency and the severity, and the scoring is weighted according to the severity of act, okay? The physical aggression gets more points than the verbal aggression. The nurses feels it every day in our ward. So we can see here that prior to hospitalization and at hospitalization, the score was high, and it was significantly lower at discharge. We also, the second outcome measure is the BPRS, the Brief Psychiatric Rating Scale, which also we can see that was high at hospitalization. It measures symptoms such as anxiety, depression, activation, hostility, psychosis. It's based on clinician rating, so it's us that rate it, so it's quite objective, okay? So we can see at hospitalization it was higher and lower at discharge. The CGI, the Clinical Global Impression, we can see that at hospitalization it was 6, which is severely ill, and at discharge patients were 3, mildly ill, so there was also decrease. And if here we try to integrate the model, so we can see how the MOAS, the aggression scores, are lower, gets lower during the hospitalization, and the children get more and more tokens for word value and for the individual objectives, as Eitan mentioned. I won't go so through it because it's right, but it's also interesting to see the different token accommodation in the children, and according to the different diagnosis. This is a child with ID. And in the future, we also want to have like a combination of what I mentioned with the pharmacotherapy, and maybe this can help us to also to how to choose the medication to lower the doses, or not like to like decision-based tool. So it's our direction.
The upper lines
Yeah.
are medications.
Medications, yeah.
And the graphs are the behavioral treatment, and we want to integrate between both, and we are very much into progress in it.
Thank you. So you understood that it works and it's good, and we have a lot of motivation to do well. Thank you. So you can scan, and Eitan will answer your question. This is the no, not now. Not now. Hmm? Yeah.